This is Dr. Sujatha Sankaran, Director for Quality and Safety for the Department of Neurosurgery at the University of California at San Francisco. We will be discussing patient safety in neurosurgery in this presentation. The topics we will be discussing are the history and background of patient safety in neurosurgery, how the current paradigm for patient safety should be expanded to include perioperative care, new updates in the field of OR safety, the use of enhanced recovery after surgery pathways, how data and training can be used to improve safety, and the importance of improving communication for patient safety. The modern patient safety movement arguably coalesced in the wake of the 2000 publication of To Err is Human, taken from Seneca's Latin phrase errare humanum est by the National Academy of Medicine, formerly the Institute of Medicine. One of the co-authors of this chapter, Dr. Mitch Berger, dedicated his AANS presidency term in 2013 to patient safety. Neurosurgery's emphasis on personal excellence over team-based care overlooks the patient safety framework. The entrenched hierarchy and the personal accountability of surgeons that is emphasized over systems approaches can lead to neglect of the patient safety framework. A study published in 2016 showed that as many as 40% of adverse outcomes in a neurosurgical sample resulted from factors that were unrelated to the technical performance of the surgery. Principles of patient safety in neurosurgery include the concept of active versus latent errors. Active errors are errors that occur when the patient is in contact with healthcare personnel and are usually readily apparent. Latent errors, in contrast, refer to less apparent failures of the organization or design and usually do not involve harm that actually reaches the patient. An example is chemotherapy being infused at the wrong rate. The active error would be a nurse programming the wrong rate into the intravenous pump. A latent error would be the healthcare system or organization using multiple types of IV pumps, thus leading to increased nursing confusion and the increased probability of an adverse event occurring. The safety paradigm traditionally only encompassed the operating room, but now includes preoperative and postoperative settings as well. In the preoperative space, it's important for systems to emphasize communication, to set expectations, to perform medication reconciliation, and to proactively obtain consultation from preoperative evaluation and pain management consulting services. In the postoperative space, certain measures can be taken, like decreasing opioid requirements, trying to prevent catheter-associated urinary tract infections, mitigating the chance of delirium, and arranging follow-up appointments and imaging studies, all aimed at improving safety across the continuum of care. The goals of a postoperative debrief is to ensure that standardized communication occurs between team members postoperatively and provides a mechanism for tracking systems issues around OR inefficiency. Postoperative debrief systems have been shown to increase safety and to improve communication, as well as to allow team members to communicate problems to one another. Volume outcome relationships refer to the often noted effect of reduced morbidity and mortality at centers that have high procedural volumes when compared to low volume centers. The World Health Organization developed a surgical safety checklist in 2008 to improve team communication and to ensure that critical preoperative steps were carried out. The hypothesis was that the WHO formalized protocol would not only prevent wrong site surgeries, but also would contribute to the reduction of other surgical complications, such as surgical site infections, ventilator-associated pneumonia, and unplanned returns to the operating room. A multi-site pilot study using the WHO checklist found a 4% reduction in complications and a 0.7% reduction in mortality. Disseminating data to individual providers is one mechanism for improving neurosurgical care. This data can give providers information about their metrics, including mortality, infection rates, and length of stay. Another mechanism that uses data to improve care is the use of neurosurgical registries. Hospitals as a whole, departments, and even individual surgeons will continue to be evaluated on quality measures with ever-increasing granularity, and large surgical registries hold the promise of generalizable data sets. Recurring themes in the neurosurgical literature around large databases are the validity and quality of the content of these databases. Calls for more granularity of data and a neurosurgical consensus on critical variables are more than aspirational. They are crucial for improving neurosurgical care and patient safety. There are legitimate questions about the relevance of certain quality metrics to neurosurgical practice. A 2017 review article analyzed the validity and evidence behind quality indicators in cranial neurosurgery. This systematic review found that there was no clear evidence for the use of a 30-day readmission rate as a suitable indicator for quality of care. Examples of metrics that may not be relevant to neurosurgery include readmission rates and length of stay, but these metrics are useful for hospital systems. Thus, it is noted that early readmission may actually represent a higher standard of care in neurosurgery rather than inappropriate care. In a study looking at craniotomy for brain tumor in the NSQIP database, it was found that the most variability in length of stay was attributable to baseline patient characteristics. Thus, while length of stay may be an important economic factor, its relevance as a quality indicator of neurosurgical care has yet to be shown. It is important for neurosurgeons to come together to define their own quality indicators, to validate them and actively report them so we can improve quality and patient safety in meaningful ways. Often, quality indicators that are proposed from an administrative level are too heavily based on economic factors. However, without input from neurosurgeons, such quality indicators will continue to drive care and policy. The case of opioid stewardship is an excellent example of how data and technology can be used to improve neurosurgical care. At our institution, the University of California at San Francisco, we've used various electronic mechanisms to ensure patient safety related to opioids. This includes a Cures Best Practice Alert that was implemented and an oral morphine equivalent calculator that identifies at-risk patients and auto-prescribes Narcan to them on discharge. This is an example of the best practice alert box that shows up in patients and reminds providers to check cures when they're prescribing opioids on discharge. Another important component of patient safety are work hours restrictions. While work hours restrictions were implemented in order to improve patient safety, study after study shows that if anything, duty hour restrictions might actually be patient safety. This came to a head in a multi-institutional randomized controlled trial among surgical residencies that found no significant difference between strict and flexible duty hours policies, with a notable difference in groups being the ability of interns to work 28-hour shifts in order to facilitate continuity care. That same study actually showed that residents' perceptions of their own well-being, as well as patient safety, were negatively affected by duty hours restrictions. Since these findings, incremental changes have been enacted, including allowing 28-hour shifts for interns. Another development towards improving patient safety through smarter training is the continued evolution of the neurosurgical boot camps at the beginning and now end of the PGY1 year. These boot camps, now in their 10th year, are attended by virtually 100% of PGY1 residents from every U.S. neurosurgical training program. Highly reviewed by residents and program directors, boot camps have been shown effective in retaining clinical knowledge. They assure directed exposure to important neurosurgery basics that can supplement infrastructure already in place in residency programs. A likely reason why these boot camps are so effective is because they make use of another evolving theme for safety improvement in neurosurgery: simulation. While in the bootcamp setting, the simulations are guided by experienced neurosurgeons and use a mix of real equipment with anatomical models. Neurosurgical simulators provide the ability for independent training with complex or unfamiliar procedures. In this way, we've come back to the idea of the volume-outcome relationship I've touched on before. It's no secret that practice makes perfect, and by allowing for more and better practice outside the OR, we can make our patients safer inside the OR. Artificial intelligence has increasingly been used in neurosurgery to promote patient safety. Artificial intelligence uses advanced neural networks to learn to perform functions like predictive modeling. AI shows much promise in diagnosis, predictive modeling, and prognostication in neurosurgery. Studies have shown that AI was able to more successfully predict outcomes of pediatric patients with traumatic brain injury than when compared to conventional models. In addition, another study showed that future low back pain could be predicted in asymptomatic patients by using artificial neural networks. Studies have also shown that preoperative risk stratification can be enhanced by using machine learning algorithms in place of conventional risk stratification, and that accelerated times to diagnosis of cranial pathology on radiography is achievable by AI approaches as compared to conventional approaches. Simulators are examples of virtual reality advancing training, and also augmented reality is a mechanism for enhancing information available to the surgeon while already in the operating room. Unlike virtual reality, where the entire image is computer generated, augmented reality involves overlaying information, such as bony or vascular landmarks, onto the surgeon's field of view. Another mechanism for improving patient safety is through improvement of communication. Communication between interdisciplinary team members, within teams, and to patients is essential to improve patient safety. Postoperative communication involves improving communication with consultants and sometimes also involves the use of a co-management hospitalist to facilitate communication. Unit-based leadership teams have been used on hospital wards to improve communication among members of the multidisciplinary team. Such teams might include a physician, a nurse, an improvement specialist, and a practice or administrative leader. At our institution, the University of California at San Francisco, we have a Center for Enhancement of Communication in Healthcare that is focused on helping providers learn how to communicate better. Improving patient communication through practice with a focus on breaking bad news and communication of preoperative risk is vital for neurosurgeons to practice their communication skills. Other mechanisms of standardizing care, such as adoption of enhanced recovery after surgery pathways, have been shown to improve quality by standardizing evidence-based care. ERAS pathways have been implemented in a variety of surgical subspecialties, and there are studies in the neurosurgical spine literature that show that ERAS pathways can decrease costs and increase quality while at the same time improving patient safety. UCSF has implemented an enhancing recovery after surgery pathway for cranie patients. This pathway has been shown to decrease length of stay, improve patient outcomes, improve patient experience while accelerating functional recovery, expediting follow-up, and standardizing care in the preoperative, intraoperative, and postoperative. Our enhancing recovery after surgery pathway includes preoperative, intraoperative, and postoperative levels of intervention. Our enhancing recovery after surgery pathway at the University of California at San Francisco for cranie patients includes standardization of multiple different domains, including mobility, laboratory work, postoperative steroids, postoperative pain medications, antibiotics, anticonvulsants, DVT prophylaxis, and the initiation of a diet after surgery. In summary, medical errors have an enormous impact on neurosurgical patients and impact patient safety as well as quality and cost tremendously. Errors Errors in neurosurgery can lead to preventable and non-preventable adverse events, and a systems approach is critical to improving patient safety in neurosurgical populations, with a focus on identifying deficits in the system rather than the individual neurosurgeon. Novel uses of data and predictive modeling present promising approaches for improving patient safety in neurosurgery.